Thank you very much for the invitation to give this talk on COVID-19, considerations for patients with bleeding disorders. When I was initially invited, the talk I was going to give and planned was very different to what I'm giving now, and I hope you'll understand why I've changed the second part of the talk. COVID-19 changed every part of the world, and here you see the impact in Canada with the number of infections earlier in the week, and as you can see on the right hand side is the deaths and cases per million of the population. But what I want to show you is that however bad you think you have it in Canada, if you compare it to the UK, the number of deaths you've had in the UK is a lot more than you've had in Canada. One of the most difficult decisions I've ever had to make was at the start of last year. I was the president of the European Association for Haemophilia and Allied Disorders, which has its annual meeting in February each year. Our meeting was in The Hague in the Netherlands, and it's a face-to-face meeting. Essentially, we had almost 2,500 persons registered, and we started learning about COVID at the start of January. At that time, we didn't know how it was going to play out, but we ended up having meetings with the Dutch authorities and with the organizers of the meeting, the PCO, every couple of days to try and make a decision as to whether we would go ahead or not. At the end, we did go ahead, and we had a very successful meeting with 2,367 attendees from 82 countries. It turned out that this was the last large face-to-face meeting in haemophilia. Since then, as you know, all meetings have gone to virtual, including the current meeting, but in addition, the World Federation and the ISTH meetings last year, and it looks like that this is going to be the situation for at least for the next few months. Coming back from the meeting, we could see what was ahead of us because we could see what was happening in Lombardy in Italy and in Madrid in Spain. Our government was 2 weeks late to lock down, and we have suffered quite a lot since. In terms of the haemophilia service, all appointments and clinics were cancelled. Our nurses were redeployed to the COVID wards. We had an active emicizumab rollout program at the time, which was suspended. Home delivery of concentrates, however, was continued, and our haemophilia center never closed throughout the lockdown. One of the best things that happened during this time is the setup of an off-site drive-through phlebotomy service where patients we speak to on the phone can drive through to this big off-hospital site with minimal contact with other people, have their blood tests and go home without having to find a parking space. For urgent blood tests, we have these motorcyclists there that can bring their samples to the hospital straight away. There were a lot of uncertainties about what will happen in haemophilia and how to manage patients with haemophilia during this time. And with a group of colleagues under the auspices of the World Federation of Haemophilia, we put together a guideline that was published in the journal Haemophilia. But essentially, we did recognize that when these patients were admitted, they would need the assistance of the haemophilia team, or at least contact with the haemophilia team, and should be managed like other patients. In March 2020, we set up a prospective registry for patients with bleeding disorders in Europe to see what happened with COVID. As you can see over a period of a year, we had 228 patients, of whom 10% died. We believe we are capturing all the deaths quite accurately, but we suspect there is underreporting of the cases of COVID to us. The one thing that stands out is the high mortality in patients with acquired hemophilia. As you can see, 11 of the 15 patients who got COVID died. This is a reflection of these people are elderly with comorbidities. They are immunosuppressed with steroids and often are either in hospital or come in and out of hospital to have blood tests. But other than this group, we don't believe that the other bleeding disorder patients behaved in any way differently. Here you see what I think is the impact of COVID-19 in patients with bleeding disorders. I do not think there is an increased risk of infection, and if patients are infected, they do not have a worse or better course of disease. Our advice is for them to continue or start prophylaxis when they're admitted to hospital. Essentially, we don't want the haemophilia to hinder them in any way. So we give them prophylaxis and we tell to the team to manage them like other patients. A number of patients have been ventilated and did quite well in some cases, but not so in others, but no different from the general population. Telemedicine has been the big impact to the patients and our lives, and I suspect it's going to continue once the pandemic is over. One thing we realize is, do we really need all the blood tests that we do when we see patients? And the drive-through service, I suspect, is going to continue. Another suggestion is really that all patients with haemophilia should be vaccinated against COVID-19, like everybody else in the population. Together with colleagues from the World Federation of Haemophilia, we've put together a guideline about vaccination against COVID-19 in patients with bleeding disorders. Essentially is in severe patients, they should have the vaccination on the day of their prophylaxis, but for a lot of the others with milder bleeding disorders, just pressure at the site for 2 to 5 minutes is all that is required. As you know, the rollout of the vaccination is happening throughout the world, but at different rates. Here I've put the data from yesterday from the Bloomberg side for the UK and Canada. As you can see, they're similar for first dose or for UK and Canada, but for the fully vaccinated second dose cases, there is a lot more in the UK than in Canada at present. The dramatic impact of the vaccination program came at a cost. Initially, the MHRA and the EMA suggested there was no increase in the risk of thrombosis, but only 8 days later, 3 groups from Norway, the UK and Germany reported this syndrome of cerebral vein thrombosis with thrombocytopenia and antiplatelet factor 4 antibodies. Unfortunately, it took the regulators another 3 weeks before they made the announcement that they did recognize this syndrome, and countries started restricting the AZ vaccine in the younger persons. Shortly afterwards, 3 major papers from these 3 groups that initially reported it have been accepted for publication by the New England Journal of Medicine, but they have not appeared in print yet. The next slide summarizes the details of these 3 papers. As you know, this condition is called VIT, vaccine-induced immune thrombocytopenia with thrombosis. And these are the first 3 of the New England Journal Medicine papers, and there are 2 other cohorts accepted for publication, as you can see, from Europe and the USA with the J&J vaccine. In Europe, it's all the AZ vaccine. The mean age is around 40 to 50. In some of the cohorts is primarily female. In the UK is more equal distribution. But the thing that stands out is the number of cerebral vein thrombosis cases that are seen. Moderate thrombocytopenia, but with a high fatality rate, as you can see on the right. Here you see the types of thrombosis you get with VIT. About 2/3 are cerebral venous sinus thrombosis, with a definite minority of portal vein thrombosis, but with other thrombosis such as more standard DVT, MPE, thrombotic strokes, acute coronary syndrome with normal coronary arteries. We have seen some cases of skin necrosis and major arterial thrombosis as well. In terms of who gets VIT, is patients who have been exposed to the AstraZeneca vaccine and J&J now, 4 to 24 days after the first vaccination, mostly previously healthy, mostly young. Average age in the UK is 48 years. In the UK is equal sex distribution, whilst in Germany it's mostly females. That's a reflection of the type of people that were vaccinated. Most cases are with the first vaccine. Very few have had previous thrombosis. So the message is that these are not people with comorbidities. Here we see the laboratory test in VIT. The platelet count can vary quite a lot, from 10 to 150. The fibrinogen is often low, but could be normal. The D dimer is usually markedly elevated, much more than we see with other thrombosis. And these patients have anti-platelet factor 4 antibodies that are only positive with the heat ELISA. I'll show you a slide later to explain this. This is a study that we've just had accepted in JTH. These were 43 samples from patients with possible VIT that were referred in after AZ vaccination, and they were tested with all the available assays. What you see on the left, these are the different types of ELISA assay. The colored circles are the ones that we thought were probable VIT, and the round empty circles are the ones that we thought, based on clinical grounds, they were unlikely. And as you can see, they were picked up quite well. On the right-hand side, what you can see in the purple, the AccuStar, which is the most widely used assay in the UK to detect HIT, was almost universally negative in this case. As you may be aware, the VIT has only been reported with the AstraZeneca and Johnson & Johnson vaccines, which use an adenoviral delivery vector. There have been no cases with the mRNA vaccines from Pfizer and Moderna, or with the other adenovirus vaccines from Russia and China. Here you see the data on number of VIT cases from the UK up to yesterday. As you can see, 332 cases, of which 315 are after a first dose and 17 after a second dose. And on the right hand side you can see there have been 24 million doses of AZ given as a first dose and 10 million as a second dose in the UK. Here you see some further breakdown of the ages of the affected persons, and as you can see, it's the younger people. But this slide is not really the best because we do not have the number of persons in each decade of age that received the AZ vaccine, and we do not know why that data is being withheld. As you can see, 17% with this condition have died. On this slide, we have added the local cases that we've had to deal with, and as you can see, we've had 14 cases, of which most are cerebral vein thrombosis. But at the bottom, I wanted to draw your attention to this condition of VIT without thrombosis, which is thrombocytopenia, severe headaches with negative MRI venogram and CT venogram, but with very high D-dimers, 30 to 50,000, and with very high anti-PF4 optical densities of 2 to 3, but without thrombosis. On this slide, I show the incidence in different countries, and as you can see, there is a lot of variation. The problem is that different ages and different reporting systems are taking place in different countries. Just to illustrate that for you, as you can see, the latest data from the UK show that the incidence is 1 in 77,000 individuals. However, here you see the incidence of VIT in the UK by week of reporting up to yesterday, and yesterday was the release of the data up to the 19th of May. And as you can see, 2 months ago the UK authorities were saying the incidence is 1 in 600,000, and now is 1 in 77,000. So the rate, I think, is unreliable when you compare it to the overall number of persons vaccinated, because you need to take age into account. VIT is very similar to the condition we've known for many years called heparin-induced thrombocytopenia that occurs 4 to 10 days after heparin exposure, more likely with unfractionated heparin, highly prothrombotic, even with the low platelets. Bleeding is infrequent, and you have antibodies to platelet factor 4 heparin complex. And the treatment is with avoiding platelets and heparin and giving an alternative anticoagulant. The management of VIT is essentially an extrapolation of what we do with HIT. We avoid platelets, give intravenous immunoglobulin to block the receptors on the platelets that activate them, avoiding heparin, giving alternative non-heparin anticoagulation, and giving alternative treatments such as steroids, plasma exchange. We've done that about 20 times so far in the UK, and giving rituximab. One of the valuable things that we did in the UK was to set up an expert hematology group. As I've told you, the announcement of VIT was on the 19th of March. We used the weekend to set up ourselves. It was 5 friends essentially. It's not an official body, but we have been meeting daily since the 22nd of March. Every day at 2 p.m, any doctor, largely hematologists, present their cases and we discuss them as to the best management options. One issue that is not often mentioned is what happens to patients who survive and get discharged from hospital. We recommend they should avoid a second dose of the AZ vaccine, but the natural history of the disorder is unknown, and the antibodies to PF4 persist for months. And we now know that both thrombocytopenia and the high D-dimers can recur, so they require close observation with full blood counts and D-dimer monitoring. And retreatment with IVIG is now taking place, and for repeated relapses we give rituximab. It is important to appreciate that we're in the early stages of this disorder, so atypical presentations can occur, such as outside the typical window. Some patients do not have a proven thrombosis. Some patients present without thrombocytopenia, but invariably the platelet count will drop. Some patients can have normal D-dimer, and we have a small number that are anti-PF4 negative. This is my final slide, and it's a self-promotion really. If you're using Twitter, you may choose to or you may like to follow me. My handle is on the right, and I've been quite active in giving the up-to-date information about VIT. Thank you very much for listening to me. I'm happy to take questions.